Talk of this session is by Dr. Radhika Natarajan, Non-Healing Corneal Ulcers, the Preferred Practice Guidelines.
Good morning, I am Radhika from Shankar Netralaya. So, a corneal ulcer may not be healing because of multiple reasons. Either it may be a very virulent organism, or the organism may be resistant to the medication, the infection may be very deep in location, the patient may not be very compliant with the treatment, there may be many bugs that are involved, or it may not be an infection at all. So, let us see some clinical situations of each of these. Here you have a deep fungal keratitis where you can see in the slit picture that the infiltrate is almost forming an endothelial plaque. So, we know that the antifungal agents being lipophilic are not going to reach there. So, this patient will not do well just with topical treatment, and after multiple intrastromal injections you can see that the ulcer is resolving, as you can see in the picture below. Here this infection does not look that aggressive, but this is a stubborn infection. This is a demititious fungus called Cladorhinum species, of which we have reported 4 cases. So, this slide is to show that even though it is not very aggressive, this takes a very long time to resolve. So, patient observation with the usual antifungals led to resolution, as you can see in the second picture, over 4 to 6 months period of time. So, that much of close observation is required before declaring this infection as non-healing, because these seldom require therapeutic keratoplasties. So, when you have a resistant infection, it may be worthwhile doing a re-scraping. There are some points to be kept in mind. A drug holiday sometimes helps. You have to scrape the leading edge of the ulcer, as you can see in picture B, because if you scrape the part which is pointed with the arrow, then you will get only scarred bits and epithelial tissue. You won't get the organism at all. And post scraping, you have to measure out the epithelial defect, because healing of that is integral to healing, especially in bacterial keratitis. And in the last picture, see, you can see a whitish scar-like lesion, but then you see that the eye is injected, it is not quiet. So, sometimes whitishness can happen even with active infiltrates in microsporidiosis acanthamoeba type infection. So, white is not always quiet in the context of corneal ulcers, that must be remembered. So, here is a mycobacterial sclerokeratouveitis. This is an infection definitely, but you see multiple pus points in the sclera and uveitis. So, there is a definite component of inflammation as well in this entity. So, the treatment is not only consisting of topical amikacin, you should give systemic antituberculous agents as well as steroid, and only the combination of 3 will bring about a resolution in this particular clinical picture. In Pseudomonas ulcers, steroids used to be a taboo earlier. But see this particular patient, the first picture shows the active stage. The second picture is when it has been treated with high concentration levofloxacin. The disease is simmering down, but still it is an angry eye. This is the right time to introduce steroid judiciously, with which you can see that with the minimal scarring and vascularization, the resolution happening in the last picture. So, viral keratitis is one of the entities where infection and inflammation coexist. We must know about this before declaring that the infection is not healing. Here you can see the immune ring in herpetic stromal keratitis, and this kind of presentation, stromal necrotic keratitis, requires therapeutic dose of antiviral and therapeutic dose of steroid to bring about a resolution, which you can see in the next picture. So, sometimes the infection is not healing because we are not recognizing it. This is a post-keratoplasty situation in herpetic eyes. When it comes on very early, it is not a recurrence, because the virus comes along with the nerves which are growing back. But see these late examples. Here you have 2 characteristic features. You have an epithelial defect which is straddling the graft-host junction, and it is also staining with rose bengal in all the cases. So, these are 2 indications that this is not just an epithelial defect, this is actually the HSV coming back, which requires treatment then accordingly. On the other hand, take a look over here. This looks like a marginal ulcer. You can see a typical lucid interval. You can see those minimal infiltrates which are multiple in nature. But then in marginal keratitis, the eye is seldom this inflamed. Here it is a suffused eye with diffuse congestion. This is in fact HSV. This is HSV blepharokeratoconjunctivitis. How you can distinguish this from marginal keratitis? In marginal, you have a dry blepharitis with a very minimal infiltrate. Here you have an angry ulcer with an injected eye. You should know the difference then, because if you treat it as marginal with steroid, HSV will flare up. So, the treatment over here is with antiviral agents. So how do we know whether there is an immune component or an inflammatory component, an immune component or an infective component when you have a corneal ulcer? There are two simple rules. One is the epithelial defect comes first in an infection. The infiltrate comes on later. Whereas in an immune disease, you have infiltration of the stroma and then the epithelium breakdown on top of it. Secondly, as you can see in the center picture, that is a Pseudomonas infection. You have a massive infiltrate, but the cornea has just about started melting over there. Contrasted with that Murren's ulcer in that corner, there is a lot of melt but very less infiltration. So infiltration is always more in infection and melt is always more in immune disease, even though the two can sometimes coexist. Sometimes there are triggers which we need to address before labeling as non-healing corneal ulcers. Here the patient is constantly on NSAID for pain relief and you can see the burrowing that is happening in the cornea. In this patient, the ulcer heals and breaks down, That is because you see the eye is not closing properly and you need to address that so that it will not recur. This is a patient in whom a bedside tassuraphy has been done in a very debilitated patient, but it has become counterproductive. You can see that the sutures and the bolster, everything are very badly applied. Bedside is difficult to apply, I agree, but these are poking on the ulcer and preventing it from healing. Also here there is a definite component of neurotrophic keratitis. You can see the unhealthy base and the unhealthy margin. There is no infective component over here. So here we have used a PROS contact lens very efficiently in bringing about a resolution. So sometimes we also need to know when to stop treating. So here is a patient who has healed completely. This is in fact a pseudocornea, which is nothing but a healed scar with epithelialized iris. So there is no infection to treat over here. What we need to take care of is keep the IOP under control from inside, from within, and avoid trauma from without, and there will be no reactivation of the problem. So sometimes the ulcer is labeled as non-healing because it is not an ulcer at all. Let me show you a couple of quick case examples. The top panel shows a patient who was referred to us with an infection following a lamella tear injury. So, but if you watch closely, the flap is necrotic because it is lifted away from the bed. So there is no nutrition to the flap. And because it's a young patient, all the inflammation is outpouring a hypopyon over there. So all we did was, like in a LASIK flap, open it up, clean it nicely, de-epithelize it, put it back and suture, and with steroids you can see that the so-called infection was only an inflammation which has resolved nicely over there. The picture below also was referred as a patient post-CXL with infection. But then you see that there are multiple infiltrates, they are whitish, they are along the circle of the riboflavin dye and the de-epithelialization that we do, and there is no epithelial defect on top. So the lack of epithelial defect and small whitish infiltrates, you know that that is a dye reaction, and again you can see in the subsequent picture that steroids have brought about a resolution. So non-resolution here is because there was, first of all, no infection at all. Here is yet another patient who was diagnosed with herpetic keratouveitis. You can see the star-studded capes in the cornea over there. But then, hold on, there was a flocculent cataract. What kind of HSV produces flocculent cataract? We got a history of trauma from that patient, and you can see where the arrow is pointing, there is a little breach in the capsule. This is in fact a phacolytic uveitis. So what is the difference? In herpetic keratouveitis with a cataract, you need to subside the uveitis before doing the cataract surgery. Whereas here, doing the cataract surgery under steroid cover is the treatment. It should be done primarily, which then brought about the resolution in this particular patient. I'd like to close with this last and favorite slide of mine. This is a young girl with a systemic disorder in the form of lichen planus, which was not treated very well. She developed a bacterial corneal ulcer like any other. We scraped her, streptococcus positive, and she was on adequate medication. She was healing. And then with healing came vascularization, as you can see in picture B. When the ulcer was active, there was no melting, but the vascularization, because of the hyperimmune status of the patient, brought about with it melting. So we actually had to recess the pannus, which is seldom done in infectious keratitis, and then in picture D, you can see that the infiltrate is scarring down. So goes to show that when two diseases are in play, both need to be taken account of. Otherwise, it could be labeled as non-healing, and the course of the disease may differ. So with that, I wrap up my presentation and open to questions, and thank you very much.
Thank you, ma'am, for your comprehensive talk. I would like to ask Dr. Revati ma'am's comment.
Thank you, ma'am. PTM keratitis. Correct. Yes, ma'am. Actually, I have very typical pictures of a pythium keratitis causing a peripheral melt to be contrasted with a Moran's ulcer causing a peripheral melt. So, like I already touched upon in my talk, we need to weigh in besides history and the way the disease progresses. These are all indicators, but what I take as the most important factor is the relation between the infiltration and the melting. So, I always believe that infiltration is a very major component of infection. And the melting comes later when the keratocytes are eaten up by the organism. Keratocytes are eaten up because of the immune response caused by the organism. Whereas infiltration is not that prominent in a primarily immune disease. You have a little bit of infiltration and the guttering happens much more prominently in a Moran's ulcer. So if I see, I have the picture somewhere, not right now in my presentation, the pythium keratitis which causes the peripheral gutter, even though it may not have the actual features of pythium like your endoexudate or your tentacles on the periphery or reticular nature of infiltrate, you will have a lot of infiltration in the cornea. You will not have a quite cornea and just a peripheral melt. So that may give you a clue that you are dealing with an infection. There is a third type of presentation also. You have immune melt, you have infective melt, and you have immune melt with a secondary infection. So that is a third way in which you can have a melt presenting. There again you will see the gutter coming on first, and then there when the infiltration happens, it is not very angry. You just see a little yellowish or a whitish base, which then may be scraped and antibiotic may be added. So these are three different ways in which you can have the clinical picture. Totally agree, ma'am. The overhanging edge is a pathognomonic feature in Moran's ulcer, number one, and it is for diagnosis. And treatment-wise also, I'm glad you touched upon it. It is very important to debride that overhanging edge because it is a source of inflammatory material, and B, it is a source of non-healing. The epithelium will never bridge the ulcer no matter what you do when that overhanging edge is there. So you need to debride it to be able to bring about resolution.
Yeah.